So I would like to start. I would like to start by apologizing to our speaker for the delay. I was hoping we would get more customers, but it's Thursday afternoon, evening, and it is what it is. It's a great pleasure for me to introduce Dr. Dayashankar Maurya. He got a PhD in 2015 from the Lee Kuan Yew School of Public Policy, and he's worked in India, he's worked in Japan, and now he's back in India as an associate professor in the Department of Social Sciences at the Institute for Rural Management in India. His presentation tonight will be on managing partner opportunism in private-public partnership, PPPs. Dr. Maurya, the floor is yours. As we agreed before, it's going to be 35-40 minutes presentation followed by Q&A. The floor is yours.
Thank you very much. Thank you very much for giving me opportunity to present my work. I will straight away go to the paper. This paper basically demonstrates the interlinkages between the institutional arrangement, the governance mechanisms. When I refer to governance mechanism, we are focusing on inter-organizational governance and how this institutional arrangement, governance mechanism influence partner opportunism and ultimately the effectiveness or performance of public-private partnership. This paper was published in Public Management Review. Overall, the key argument is basically the PPP, as we all know, is a very complex arrangement, and this is an public partner opportunism. That means cheating behavior by a partner is one of the main reasons for failure of PPPs. And this risk becomes much higher in case of healthcare or in case of sectors which are basically have high or deep information asymmetry and outcome uncertainty. This challenge further increases in case of developing country context where there are institutional voids, because effectiveness of PPP significantly also depends upon the institutional arrangements. And in case where there are either there are gaps in the institutions, or formal institution as well as informal institution, generally what happens is that these arrangements adopt what is called as private order institutional arrangement. That means they do not really depend upon the formal judiciary or for resolving any dispute. Rather, they come out with a inter-organizational arrangement, which is called as private order institutional arrangement, to address any grievances or address any disputes that arises during the implementation of the PPP. We studied one of the large national health insurance program in India, which was basically designed through a public-private partnership. And we find that it is the weak political and administrative institution along with institutional voids led to capture of even these private order institutional arrangements and ultimately leading to poor enforcement. So the basic argument has been that in absence, because of institutional voids, the PPP arrangements adopt private order institutional arrangement, but even those private order institutional arrangements will fail because they require support from the formal institutions. And the literature on health policy or even in PPPs have actually not focused much on the governance part of the PPP, and they have largely focused on the design aspect, and therefore this is the area where this paper contributes. In generally, PPP has been known as an important policy tool. It has been adopted significantly even in developing countries, even in the context such as healthcare, education, social welfare, and others. As explained earlier, opportunism or cheating behavior remains a key reason for the failure of PPP. But the literature, only few studies have focused basically about how PPP arrangements manage partner opportunism. And this risk of opportunism or cheating behaviors by partners is much higher in emerging economies because of it requires a level of maturity of institutions. So the question that this paper was trying to answer is in such a context with institutional voice, how PPP arrangements manage partner opportunities. So it is a kind of an exploratory work along with based on the literature, we come out with a set of hypotheses, and using a comparative case study, we examine in the case that to what extent and how in institution context of institutional voice, PPP arrangements manage partner opportunity. Now, some definitional terms. What is opportunism? As we all know, self-interest seeking with Gill. That's how Williamson defines it. Williamson also talks that controlling opportunism is central goal of any governance. We are still focusing on organizational, inter-organizational governance. We all know that all contracts are incomplete, and therefore there is always a risk of partner opportunism. It is the governance mechanisms are used to fill that gaps in the contract design. And there are two types of basically governance mechanism in the literature. One is formal governance, which comes from transaction cost economics, and the relational governance, which comes from relational governance theory. The differences are in formal governance, the parties primarily depend upon a contract as an instrument of control. The contracts are well written, and there will be monitoring, sanctions, and transactions. So kind of a hands-off approach to managing the relationship. Whereas relational governance theory basically focuses on arises from the literature on relational governance, and basically focuses on the relationship between parties. So relational norms, trust, flexibility. The contracts in these cases are loosely defined and less rigid. Now, literature basically is kind of inconclusive when it comes to how partner opportunism, which governance mechanism or what is the combination of governance mechanism that could basically effectively manage the opportunism. So the literature is kind of inconclusive because it has found that it is when it is used alone, either relational or formal, they can increase. When it is used in combination, they have been found to decrease as well as increase. Some studies find relational mechanisms more effective. The argument is trust between parties, reduces the opportunistic tendencies, develops better understanding, common understanding between parties. And whereas other studies have basically argued that no, it is the formal governance mechanism, that is trust has a darker side. Now, these are empirical work, so it is not built on theory, but it is built on the empirical existing review of the empirical studies. The more or less the understanding is how the governance mechanism combine and substitute and complement each other when deployed in combination. That is, and how they adopt over time, that has received limited attention. And we are trying to look at this kind of a micro stuff, how between two organizations that are in partnership, how they deploy different governance mechanisms, how they combine them, how they assess which, what is the need of which mechanism is more suitable, they deploy it, they assess its effectiveness, redeploy it, and how this process evolves. So this is what this paper focuses on. Now, based on the literature, we looked at, okay, what we know so far about managing a transaction or managing a relationship between parties. So any transaction that happens between two parties, drawing from transaction cost economics, is that any transaction has some need, governance needs, and this is based on what is called as three characteristics: frequency of transaction, uncertainty, and asset specificity of the transaction. And these governance needs determine the kind of this transaction characteristics determine the kind of governance need. That means what the governance mechanism should provide. So, and that has been defined in terms of incentives, control, and trust. Governance mechanisms have been divided. For example, formal governance mechanisms primarily provide control and incentives, whereas relational governance mechanisms primarily provide trust and social norm. The idea is, if governance mechanisms supply the need of the transaction, governance need of the transaction, then the governance mechanisms will effectively govern the transaction, and therefore the opportunism behavior will not be observed. So that is our hypothesis one. But in case the parties deploy the governance mechanisms and that deployed governance mechanisms do not address the needs of the transaction, then the partner organization have to keep on adopting that governance mix until the governance mechanisms align with the governance need. And this will happen, this will also involve how the two governance mechanisms or different components of the governance mechanisms substitute or complement each other over time. So overall, if the governance mechanisms fail to control partner opposition, they will keep and changing over time until such an alignment with the governance needs happen. Now, do parties have complete freedom in deploying governance mechanisms? Not necessarily, because the meta governance rule, so rules in public administration, the broader rules that determine what can be included in the contract, what kind of incentives, penalty mechanisms, monitoring, sanctioning, how the bidding process happens. So the broader meta governance rules will determine whether a particular party in the in PPP, what kind of governance choices they have. Also, the formal institutions and informal institutions will determine whatever the choices they make in terms of governance mechanism, whether those choices will be effective. For example, if there is a dispute whether the parties can go to judiciary, and if the judiciary has a huge number of cases, which is common in India, and the decisions are, or the processes are extensively delayed, like 10 years or 15 years. Therefore, the parties may not, so going to judiciary in case of dispute may not be a good governance mechanism. So this, as we discussed in previous hypothesis 1 and 2, the alignment between mechanisms and governance needs will be constrained by institutional voids, because institutional voids do not allow the parties to adopt or use governance mechanisms that are needed for the transaction. And if they cannot deploy those governance mechanisms, then what happens is that the governance needs are not met and the opportunism is not controlled. The partners are left with suboptimal choices. That means they will use the governance mechanisms that are possible and available, and that will resulting in a situation of what is called as second best and a suboptimal control of opportunism. The idea is the partners will tolerate the opportunism of the parties as long as there is some minimally acceptable level of profitability. So this leads to hypothesis 3 and 4, which is primarily developed from the literature. This is basically the theoretical framework where let me, yeah. So this is basically the governance needs, which is determined by the nature of a characteristic of transaction, asset specificity, uncertainty, and frequency. That determines what the governance needs are. The parties will have governance mechanisms, that is in terms of contracts, relationship, monitoring, sanctions, penalties, flexibility, solidarity, trust. And when the governance needs and governance mechanisms are aligned, it will lead to effective control of partner opportunism. But if the alignment does not happen, that is hypothesis 1, there will be partner opportunism. Partners will engage in cheating behavior. So if one partner engages in cheating behavior, then the other partner discovers it and deploys governance mechanism, keeps on adopting governance mechanism until it is aligned. but this adaptation will be constrained by the institutional voice and that is the hypothesis 3. And then in those cases when because of institutional voice, this governance adaptation is suboptimal and that does not lead to alignment, then it will lead to suboptimal control of a so basically, again, what is a dependent variable is partner opportunism, exploratory variable 1 and 2 as alignment and institutional voice. Governance needs have been defined based on the literature as incentive, control, and trust, and governance mechanism has been categorized into relational and contracts based on the existing literature. Now, the context for this research is National Health Insurance Scheme, which was implemented in 26 provinces and 482 districts in India. This National Health Insurance Scheme is basically implemented through a public-private arrangement, where it is there is a conglomeration of public and private agencies. I will explain the structure a little later. The insurance this mechanism basically provides insurance coverage of up to 3,000 per family, and the healthcare services are provided through a network of around 12,000 hospitals across India. The scheme basically, the task is to first to enroll the beneficiary in the scheme and then provide them hospital-based healthcare services through contracted providers. Now some basic program design. So the funding, who funds how much, who are the beneficiaries, and what are the benefits, and the implementing agency. However, the most important part, I will just focus on the most important part, is the structure of the design of the PPP arrangement. So here is the national level ministry at the federal level, Ministry of Labor and Employment, and state government within each state. As I said, there are 26 states in which the scheme was implemented. So the state government and Ministry of Labor, they engage in an MOU. The MOU basically about funding and so on. The Ministry of Labor basically comes out with the overall structure of the scheme in terms of the contracts and everything, which will be implemented uniformly across the scheme. The state government nominates a state nodal agency, again another government agency, who is responsible for day-to-day implementation and operations of this scheme. Now, this is at the state level. Now, within a state, there are a number of districts. For example, one of the state which we examine, there is in one state there are 72 districts. Now, one district is considered as the implementation unit of this. Now, here for each district, the state nodal agency will contract with an insurance company, public or private. It could be private insurance. Now, this contract is on basis of premium per family. That means the number of families that are enrolled in the program. For each family, the insurance company received a fixed amount of money. And then the insurance company provides the health insurance to that enrolled beneficiaries. Now, what insurance company does is, insurance company will enroll the beneficiary in the program through what is called as smart card service providers. They will, and this smart card, once they are enrolled in the program, then this below poverty line people, families basically will go and visit hospitals, public or private, and they will take care from that hospitals, and the hospitals will submit the claims to insurance company. These hospitals are also impaneled in the scheme by insurance company. And all this back office operations of the insurance company is managed by a third party administrator. So here insurance company is a private player, third party administrators are private player, hospitals are both public and private, smart card providers are private players. And all these contracts between insurance company third-party administrator, hospital, and formal between insurance company and smart card providers is kind of broadly defined in this contract, which is between state nodal agency and insurance company. Now, this contract is same across all districts. The roles of all agencies are same across all districts. The number of agencies, there were around 15 insurance companies that participated in 400 plus districts. There were some 21 third-party administrators that participated across 482 districts. So same insurance company was present in multiple districts and same third-party administrators. In each district, there were numerous hospitals that were impaneled. Now, the whole process at the district level is facilitated or supported by district administration. Now, this district administration is nothing but a district level government authority. In Indian context, we call it as district magistrate. This district administration will help the insurance company to find where the beneficiaries of the program are so that they can enroll them. They will advise on the hospitals that are available, that are good in the district, so that insurance company can impanel them. In case if there are complaints by beneficiaries and so on, the district administration will inform the insurance company. The district administration also serves as a head of the district grievance committee. That means in case there are disputes between insurance company and hospitals, and insurance company and hospitals and beneficiaries, then those disputes are solved by a committee and which is chaired by district administration. So there is as I said earlier, because all contracts between different agencies are incomplete, and because of that, they have thought about that there will be disputes between agencies, and they came out with district level grievance committee, state level grievance committee, and national level grievance committee, which are supposed to address dispute arising at different levels. Now, as from the literature, we know that all contracts are incomplete, and there were issues because the contracts do not specify clearly the output, outcomes, and quality, because specifically in healthcare, these are very difficult to measure. So, for example, the contracts were extensively detailed in terms of what all agencies should be doing. The processes were laid down extensively. But when it comes to outcomes, for example, the reduction in mortality, morbidity, or health improvement, that has not been defined. Also, the quality aspects of healthcare, that means the quality of care that should be provided, that has not been very explicitly defined. Their input indicators or input quality materials were quality related to inputs were explicitly defined. For example, what kind of hospital can be impaneled, what kind of third-party administrators could be there, what will be the quality of smart card that will be given to the beneficiary. So those were explicitly defined, but as far as outputs and outcomes are concerned, or process quality is concerned, that is not very explicitly defined. And even when it is defined, it is not measured. That was the big issue. Because of the challenges itself, the challenges in measuring and monitoring this. Also, the other issue was the incentives were primarily tied to inputs and not outputs and outcomes. So, for example, the insurance company received their payment, that is premium per family, based on the number of beneficiaries they enroll in the program. But it has nothing to do whether the beneficiaries received any hospital-based services or not. So as long as insurance company enrolled the population, it kept on getting. Similarly, hospitals were paid based on the number of packages. So there were some 1,200 packages of healthcare, appendectomy, tonsillectomy, and so on. So 1,200 packages were identified, And if the hospital provides, the hospital has complete autonomy to select whatever package is needed in that case. And they submit the claim to insurance company, and insurance company reimburses the claim based on the package rate that has been defined. This package is also standardized across the state, across country, across all implementation jurisdictions. The third party administrators were paid kind of service fee per family, per card. The smart card service providers were paid a fee per card or fee per family enrolled in the program. So here we see that all the payment mechanisms were primarily tied to the inputs. And because of that, there is natural tendency to induce volume. So insurance company try to enroll maximum population. Smart card services were try to enroll more families. But at the same time, whether the outputs in terms of whether the healthcare services are received, status improves, all that has not been, there has been no incentives for that. Also, the quality parameters were defined, but it is not monitored, and that led to shedding of quality. Another big issue was district administration, which is engaging in collusion and rent seeking. Now, this issue emerges because in each district, there are a set of private hospitals. Now, these private hospitals, which are located in rural area, saw this as a money-making opportunity in the scheme, and therefore they wanted to get empaneled in this scheme. Even though they didn't have required qualification or standards. They reached out to the district administrators and tried to collude with the district administrators, bribe them to get empaneled in the scheme. The district administrators will force the insurance company to empanel these hospitals. And once these hospitals were empaneled, they engage in blatant frauds. This leads to this leads to a vicious cycle where the hospitals bribe their district administration force the insurance company impanels this hospital. Once these hospitals are impaneled, they go on blatant fraud and opportunism. Now, the insurance company can de-empanel this hospital or remove this hospital, but they have to take consent from the district administration, because district administration is the head of the district grievance committee. And therefore, without their approval, they cannot remove this hospital. So now this hospital cannot be removed and they continue to engage in frauds. Now, to control their fraud, insurance company engages in counter frauds, counter opportunism. It's natural in the literature which talks about tit for tat that happens in this kind of arrangements. So this vicious cycle ensued in various districts, specifically when district administration colluded with insurance company. Now, so a number of cheating behaviors or opportunistic behaviors were observed by each of the stakeholders in this scheme: insurance company, hospitals, and district administration. And to control or to manage those cheating behaviors or opportunism, the contract between the insurance company and state nodal agency has a number of explicitly written governance mechanisms, monitoring, and primarily the penalty was only the termination of the contract. So contract could be terminated, and then the party could be blacklisted, and that is possible. But apart from that, penalties, monetary penalties, and those things are not included in the contract. Now, one of the key opportunistic behavior we examine in this paper is collusion between hospitals and insurance company, as we have discussed in the last slide. And so what we do in this paper is basically we study that how parties deploy different, specifically the insurance company, deploy the different governance mechanisms to control opportunism by district administrators. And for that, we required a case because we were looking at how about the performance of the scheme across states and the unique design of the program where competition between agency, population characteristic or incentive structures in the contract, implementation processes, institutional environment and resource allocation is more or less same across all implementation units. And therefore, it was much easier to tease out the deployment of governance mechanisms and their effectiveness in controlling opportunism and ultimately the performance of the scheme. So we went through a number of stages. So initially there was a preliminary research. We went through document analysis and preliminary interviews. Based on that, we selected 3 provinces based on variation in institutional effectiveness. So one province where high in public corruption in public services or low contract enforcement, and another province which is moderate, and the third which is kind of highest in terms of corruption and low in terms of contract enforcement. Then within that, each province, we selected one district as an implementation unit. And then within that district, we collected data from all stakeholders. So all stakeholders means the state nodal agency, the insurance company, hospital, third-party administrators, smart card service providers. We interviewed everyone. And apart from that, there were some informal discussions and direct observation, field visit in terms of attending meetings at national, state, and district level. We did contextual analysis in 3 areas, functional areas, so 3 functions: the enrolling the beneficiary into the scheme, impaneling the hospitals in the scheme, and once this hospital submit the claims, then managing how the claims management happens. And throughout these 3 areas, we identified the opportunistic behaviors, the organizational responsibilities, and how the factors drive that opportunistic behavior, and then how organizations manage those opportunistic behaviors. So the broader research involved all opportunistic behaviors, but in this process, we focus only on one of the key opportunistic behaviors, that is collusion between hospitals and district administration. And then we did process tracing and cross-case analysis. So these were the 3 states that were selected: Himachal Pradesh, Uttar Pradesh, and Punjab. As I said, corruption in public services in Himachal Pradesh is quite low. Uttar Pradesh has an alarming, and in Punjab it is moderate. And the population below poverty line, human development index, and infant mortality. The state also differed in share of private hospitals and in the scheme. So number of hospitals that are impaneled in the scheme, which district has the, so Uttar Pradesh has a high number of private hospitals that were impaneled. Himachal has lowest, and Punjab has somewhere around half of the hospitals were from the private sector. But when it comes to claims, all the claims basically in Uttar Pradesh were primarily from private hospitals. In Punjab, it was roughly the half, and whereas in Himachal Pradesh, the public sector hospitals dominated in claims as well as in death. Now, this is important, and we'll talk a little later about why this is one of the key contextual factors that determine the cheating behavior or opportunism by district administration. Now, for each opportunistic behavior, we find out who is the aggrieved and aggrieving organization, the context and structure that drives that behavior, the sequence of governance tools that are used to prevent and control the opportunism, and why the partners selected those governance tools, how they assess their effectiveness, and then how they combine different governance, the sequence of tools that are deployed, and how they go about from one tool to another tool. So these are how we define the governance tools based on the literature, formal and relational governance tools. We mapped based on the literature, And this is basically for the purpose of validity and reliability, the process we follow to ensure there is strong internal and construct validity and external validity as well as reliability. Now I will jump to the findings as there is just 5 minutes left and I have received a message from the Meera, so I will just jump. Now the basic idea I have explained, but here what happened is we'll look at the contextual factors that determines what is called as uncertainty or opportunistic behavior of the district administration. One, the main factor is how much the insurance company is dependent on district administration. And that determined based on quality of BPL list, the state government pressure on district administration to complete the enrollment of the beneficiaries. And the second is the proximity of district administration with the hospital. So what is the share of private hospital participation? How has been the connection between the district administration? Now, the district administration always has two choices. One is if the hospitals are engaging in fraud, the district administration can support insurance company and can control the fraud. Or district administration can himself collude with hospitals and force the insurance company to impanel these hospitals and prevent the de-empanelment of these hospitals. The idea is if the insurance company is more dependent on support of DA and there is a strong proximity of DA and hospitals, in those cases there is more risk of DA colluding with hospitals, because if insurance company is more dependent on DA, then DA can exercise as insurance company is dependent on district administration, then district administration can exploit that dependence of insurance company and force the insurance company to impanel a set of hospitals. And this collusion also determined by proximity to what is the connection between district administration. Now with this, we map across 3 states. Now, this has been explained in detail in the paper. If somebody is interested to know more about it, but overall, if we see, so in Himachal Pradesh, there was low dependency of insurance company on DA and limited proximity of DA with private hospitals, and that led to limited risk of collusion. In Punjab, it was a high moderate risk, and in Uttar Pradesh, it was a high dependency of insurance company because the BPL list were very old and dated, and so that led to a lot of conflict in the field. The insurance company required support of police to address those disputes that happen in the field in villages, and therefore it was highly dependent on the district administration. In Uttar Pradesh also, as we saw in the previous slide, so about 60% of hospitals were from the private sector, and 90% of the claims were coming from the private sector. So there was the share of private hospitals was much higher, and also the district administration was basically from Department of Public Health, and because of DOH, Department of Health. Since they were from Department of Health, they were very strongly connected with the private hospitals and owners of the private hospitals in the district. So that proximity was there. In Punjab, it was not there. It's primarily because the share of private hospitals was low, and there was a strong indication or strong instruction from the state nodal agency that the district level at district administration should not interfere, anything between insurance company and private hospital. In Himachal Pradesh, the situation are exactly opposite, because the insurance company and DA has limited proximity, and the DA was from a rural department. He was not from Department of Health. So they didn't know private hospital. There was limited connectivity. Now, all that determined basically the uncertain behavior of DA, and based on that uncertain behavior, that governance needs varied. So in Himachal Pradesh, it was incentive correction trust or control requirement was low. In Punjab, it was moderate, whereas in Uttar Pradesh, incentive correction was needed because there was distorted incentive of insurance company. Now here, it's just that
I think
how,
the time is up. The time is
yeah,
up.
yeah.
Yeah.
So yeah, so that how insurance company went upon managing those, and then basically how the grievance redressal mechanism that was captured because of the district administration. So overall, this paper basically talks about challenges of governments in emerging economies in implementing those large national programs. And specifically, if the judiciary is weak and poor legal enforcement, the PPPs adopt these private institutional arrangements. But because of the same reasons, these arrangements will get captured and lack enforcement. So then in those cases, the organizations manage it suboptimally. This is some of the few related work which we have extended the analysis further and has been published so far. So thank you very much. I am happy to.
Thank you very much.
forward to the question.
Let's open the floor for Q&A. Don't be shy.
I have a hard time finding the raise your hand button, but I can raise my hand here.
Okay,
Can you hear me?
I sung first and Omar
No,
second.
no, Omar, go first.
Okay, go
Okay,
ahead.
Omar goes first.
I was looking for the raise your hand button, but I couldn't find it. I have two questions. One is, first of all, thank you for really nice presentation and really interesting topic. And I approached similar topics from a different perspective. I'm an economist by training, and I'm looking at from the strategies, looking at similar problems from strategy space. And hello?
Yep.
Yeah, we can hear you, Omar.
My screen is frozen, so I don't know if you can hear me.
Yeah, we can hear you.
Okay, my question is basically, in your theoretical framework, how do you ensure incentive compatibility? What is the incentive by participants? Actually, I did not see that many, the strategy space for the participants in the mechanism to stay and continue in the game in a self-enforcing manner. The second part is more about this enforcement. I believe in your system, everything depends on whether the district administrator is corrupt or not. Once the district administrator is corrupt, all kind of possible variations of corruption or variations of problems arise. But how can we ensure district attorney has, I mean, how can we ensure its strategy proofness here? Like, if the benefits are attractive enough, then it will attract more corruption-prone individuals towards the weaker part of the link. I mean, weakest chain in the link. How the mechanism actually prevents this as a self-enforcing mechanism.
Okay, thank you. So can I respond to now or should I wait?
Sure, you can respond right away.
Yeah, okay, thank you. So if you see the incentive compatibility, if I can share the slide again. So if we see the incentive compatibility, yeah. So here, so insurance company receives a premium per family, and therefore they have high incentives to enroll beneficiaries and manage the claims or manage the hospital claims that are coming to them, so as to make sure to keep the cost low, so that their profits will remain significant or appropriate. On the other hand, the hospitals, they are paid on the basis of package rates. So they will like to treat and provide more and more packages to the patients. Yeah, and their interest is to get more and submit more and more claims. So that way, the insurance company and hospitals are kind of bidded against each other. Yeah, and the state nodal agency is contracting only on premium per family, and therefore the risk of cost escalation, which is very common in health insurance programs, is not there, because they have a fixed amount based on the population or the number of families that are enrolled in the program. So the insurance company has an incentives to reduce the cost, whereas the hospitals have incentives to increase the hospital packages or incentives to provide more treatment to the beneficiaries. So this is how the insurance, the incentive alignment or incentive compatibility between insurance company and hospital and the state nodal agency was trying to align, so that it leads to what is called as self-enforcing mechanism between the parties. Also, the insurance company can impanel a hospital or de-impanel a hospital if the hospital is engaging in too much fraud, not genuine claims. Hospital also can complain to district administration and to state level state grievance committee if they are not happy with the insurance company. The state nodal agency which contracts the insurance company can also, because these contracts are only for 1 year. So contracts for 2 years, but renewal every year. And therefore the state nodal agency can also remove the insurance company next year. It can blacklist the insurance company. So this is how what is called as the mechanism design or the self-enforcement was achieved. Now, going back to the question of enforcement, yeah, of course, the key is, as you have rightly said, is the district administration and the behavior of district administration, whether he colludes with the hospitals or does not collude with the hospitals. Now, the collusion, as we looked at the based on our analysis, we found that collusion dependent on a couple of things. One thing is if the district administrator was from a field of health, from medicine, then he knew the private hospital and was easily developed some contacts and collusion developed. Also, if the insurance company was too much dependent on district hospital for support during the implementation process. If the insurance company required the support of district administration, then district administration exploited that dependency. If the insurance company didn't require much support, the district administration could not really force insurance company to do that, to impanel their favored hospital. That was the another issue. Also, it also determined about the state nodal agencies' behavior. If the state nodal agencies can, or state nodal agency through the state government can enforce control on the district administration, because district administration is nothing but a public official who is posted at the district level. Now, the state government can use their authority to enforce district administration, and that was observed in case of, for example, in Punjab or in Himachal Pradesh. So, unfortunately, I didn't time well, but in case of, for example, in case of Himachal Pradesh, yeah, the state government supports SNA. State government, district administration does not play any role in hospital empowerment, and as a chair has no conflict of interest, and therefore in Himachal Pradesh, district administration is not playing any role. And even if there was one small complaint of hospital fraud, the state nodal agency initiated a very strict action, legal action, criminal investigation. So state government issues criminal investigation against Ealing Hospital. And therefore hospitals were also very afraid. So how the enforcement happened. So I talk about in the paper about how this private institutional arrangement gets captured and how how the enforceability of PRGS or private grievance redressal system determines the effectiveness. So asking about, so I think that's answering the second question. Yeah.
Song.
Okay, thank you for Professor Maurya. Very interesting presentation and complex and very difficult to understand. So limited my understanding, I want to ask something. First one is the measurement issues. Kind of you thinking, I think you did some case study, 3 province, and then you all cases, I think you check it. I think you have several thousand cases. And you think you said a critical incidence analysis, which means each case you decided this one is opportunistic behavior result or not, or this is the controlled opportunistic behavior, because you have 3 dependent variable, right?
Yeah.
And then so semi-optimal, and then maybe controlled opportunism, or partner do the opportunistic behavior. 3 level dependent variable you said before, right?
Yeah.
So how do you distinguish? How do you decide it? Each case, critical incident analysis. I'm curious how to do this one, critical incidence analysis. That's the maybe depending that related to the dependent variable yours. So that's my first questions. And second question is it looks like you do many principal and agency, right? So it's 3 levels. First one is maybe the state DA or state nodal agency, insurance company, and then TPR and the individual hospital and the card companies. How do you distinguish? It's a very complicated level because a 3-level contract. So, for example, insurance company become an agency, also become a principals, right? So how do you you distinguish these things? That's my second question. And then in third question, maybe minor one, is that collusion means you show the result of a collusion, which means opportunistic behavior. That's why you said a collusion. The district, they have some issues or suing each other. And then you said a risk of opportunistic behavior. Opportunism by DA means district agency, right? So usually DA is the principal, not the agency, right? Then opportunistic behavior usually do the agency doing. Yeah, thank you.
Yeah, so thank you very much. I will try to answer based on I think I have based on your question and whatever is the understanding I have got from your question, I will try to answer that. Now, the first thing is about the measurement issue and what I wrote, the critical incidents analysis. So it is critical incident analysis is one of the techniques in qualitative analysis where when you are trying to understand a process, you identify critical movements, and then around those critical movements, you try to identify the factors. So that is one thing. So the 3 critical movements are basically in the implementation, the enrollment of beneficiaries, empanelment of hospital, submission, management of claims, the 3 functions, and within that functions, again, certain smaller level incidents and how the parties behave during those incidents. So that is the, when we talk about process tracing, these are the critical incidents that we identified. And based on that, around that incident, we try to identify factors that led to those critical incidents. So
my question is a dependent variable. You said a dependent variable, 3 levels, suboptimal, and then control the opportunism, and
Yeah,
then
yeah.
cannot control the opportunism. How do you
Yeah.
decide these three level dependent
So this
variables?
is, yeah, so this is basically decided on three factors. One is the data that we have got on what is called an extent of fraudulent frauds, which is somewhere reflect of claims, hospital claims. So for example, in the district in Uttar Pradesh, the claim ratio is 700%. So 700% claim ratio suggests that it is not something because of the pent up demand. One of the explanation is pent up demand. The population didn't have access to health services for a long time. Health services become accessible and the population started using it. But 700 claims that are coming from one district, 700% claim ratio, sorry, 700% claim ratio that is coming off from one district. 40% of the claims had 1 day of hospitalization. That means the patient was simply admitted and discharged on the same day. So that emerged from Uttar Pradesh. Okay. Now, based on this hospital's claim ratio and looking at hospital level, the claims data, we could find out whether the hospitals were engaging in extensive fraud. And then there was also significant amount of reporting from the newspaper and other gray literature that emerged from each state. Third, we relied on, apart from this, some quantitative proxies, we also relied on a lot of qualitative information that we got through. We triangulated this from qualitative data, which is come from the interviews. So one of the key data came from the reinsurance company. Now, insurance company, I will explain. Insurance companies are reinsured by another agency, because if they are expecting too much claim ratios or loss, they reinsure themselves. So these reinsurance companies are operating in multiple states, and there are few reinsurance companies, and they knew that how these hospitals were in which states, how the hospitals were operating and behaving. So we got qualitative data from reinsurance companies, from insurance companies and their field level staff, from what is called as third party administrators and their field level staff, and for a comparative analysis, we relied on the claims ratio data, which was available across districts and across states, and the feedback coming from the reinsurance companies. So within the state, there was enough amount of qualitative data which was coming from the field level staff, and for a comparative analysis across cases, we relied on. Now, how we define whether it is suboptimal opportunism or full-blown opportunism, or in other words, blatant opportunism, and no opportunism, that is the issue. So when we talk about no opportunism or controlled opportunism, we meant basically looking at the hospitals in terms of the claims ratio, where the claims ratio were expected around, or the claims ratio was not significantly very higher, and also the reporting which came about the type of cases. For example, if this the number of one-day hospitalization, the number of hospitalization of particular disease category, which was expected to be much more in case of opportunistic or frauds by hospital, and of course a lot of secondary data which came. So control opportunism was observed in Himachal Pradesh, where we didn't find also many disputes between insurance company and hospital, because if there is a fraud by hospital, the insurance company starts losing the money, and they start trying to de-empanel the hospital, try to control the hospital, and they engage in counter opportunistic behavior. They will not honor the claims coming from the insurance company. But this was very low in case of Himachal Pradesh, was very high in case of Uttar Pradesh, and was somewhat moderate in case of. So that is the first question about measurement issue, which was done through triangulation. Of course, we didn't rely on one indicator, multiple sources, and try to triangulate information from multiple sources. The second question, I think, was about principal agency relationship. So yeah, so if we see the structure of the scheme, it is multiple principal agent relationship that we can see. Where if we see the state nodal agency is a principal, insurance company is an agent, then hospital becomes an agent and insurance company becomes a principal, third party administrators becomes an agent, and smart card providers becomes an agent and insurance company. Yeah. So I'm sorry, I lost Professor Ha.
Yes.
I just
So
got
how
that.
do you distinguish? Because this is 3-level contract, and then
Yeah.
one become can be agency also principal. How do you distinguish this principal agent's role? And then this 3-level. So did you check the all level, right? All 3-level you check the
Yeah. So the dynamic primarily happened here between principal and agent, and then at this level. So I checked right from at this level, as well as all up to insurance company going up to the hospital, and insurance company going up to the smart service providers. So all 3 levels basically. The structure is same. It is not the structure is not determined. The structure is determined the same across all the states, across all the districts. I mean, the implementing units is the same structure. All the structures and processes are explicitly detailed in case of the contract between social SNA and insurance company. So this contract will tell insurance company which hospital to impanel, what should be the criteria. The payment mechanism is also defined based that what are the packages, how the packages will pay, within how many days claims has to be paid, and all that has been determined ex ante. So this contract determines the relationship, this terms of relationship. So at level 2, principal and agent, all this relationship is already determined in this contract. So this is called as principal contract basically. Sorry, a third question was
Yeah, in the case, I mean, one of your results showed us the risk of opportunism by DA, but DA is the principal, right?
DA, yeah. So
how
when
they
I say,
do the opportunistic behavior?
Yeah. So when we say absolutely, when we say DA,
So DA can be both principal and agent.
Agent. Yeah. So DA is a district level officer, and he is supposed to, government officer who is supposed to report to the state government agency. But the contract is not between DA and state and insurance company. There is an informal relationship.
Oh, okay.
So there is no direct
Okay,
relationship.
I
there is
see.
no direct contract as such.
All right.
The
Sorry,
state
I
government
confused the state
nominates.
government.
Yeah, the state government nominates and identifies a district administrator, and that district administrator basically is supposed to support. That also is included in the principal contract between state nodal agency and insurance company that they will receive. Now, but this district administration, because they have, they see also this scheme as an opportunity to engage in corruption, and therefore, if the hospitals approach them, then there is an opportunity to do so, then they engage in such a. So that's how they themselves become an agent rather than a principal.
Yeah, thank you.
Thank you very much, Dr. Maurya. I think this will bring your detailed question will brings our session to an end. We are a little bit over time. Thank you so much for a rich presentation. Thank you so much for the questions, for the participation of all our participants, and we'll meet again very soon. Thank you very much.
Thank you very much. Thank you very much. Thank you very much, everyone, for giving me an opportunity to present. I again apologize that I couldn't really talk the core aspects of the paper as when it comes to findings, but I hope you will get a chance to go through the paper where I think these aspects are explained in detail. The paper I have already shared with the Mira. So thank you very much for the opportunity to present my work, and looking forward to interactions in future.
Thank you.
Thank
Thank
you.
you very much.
Bye.
Bye.
Thank you.